Hi everyone. This is going to be a brief run through of Lab 6, most of which is going to be done as a virtual lab exercise. So we're just going to go through and hit some of the important topics so that you understand what it is that we are inspecting in those virtual lab exercises. So here we see the cover page for lab exercise 6, the heart is a pump, and the objectives that we should be able to do by the time we finish this lab. Some activities, like I said, there are some virtual lab exercises that you will need to complete on PhysioX, and some case studies that you will need to do. But let's go ahead and look at a little bit of background for this lab, just so you can understand some of the topics that we're covering. So first, cardiac output. Cardiac output is the volume of blood ejected from a ventricle in 1 minute. So cardiac output is typically measured in liters. Sometimes you will see it in milliliters as a very high number, but liters tends to make it look a little cleaner. Heart rate is, of course, how many times does your heart beat in 1 minute? And stroke volume, similar to cardiac output, but there is a little bit of a distinction. Stroke volume is the volume of blood ejected from a ventricle in 1 beat. So cardiac output, stroke volume, the difference, cardiac output, volume of blood ejected from a ventricle in 1 minute, stroke volume, volume of blood ejected from a ventricle in 1 single heartbeat. So we can actually use those three as an equation. Cardiac output, usually abbreviated CO, heart rate, usually abbreviated HR, and stroke volume, usually abbreviated SV. So cardiac output is equal to heart rate times stroke volume. And if we know any two of those, we can use them to find the third just by manipulating the equation a little bit. So cardiac output is equal to heart rate times stroke volume. Now down here it goes into stroke volume a little bit more, tells you the average stroke volume is 70 milliliters per beat. And there's another way to find stroke volume, and that is using two other volumes, the end diastolic volume, or EDV, and the end systolic volume, ESV. End diastolic volume is the volume of blood in a ventricle at the end of diastole. So remember, diastole is when the heart is most relaxed. So another way to think about this is when the ventricle is completely relaxed, when it is at its fullest point, that volume of blood in that ventricle is the end diastolic volume. The end systolic volume, ESV, is the volume of blood remaining in a ventricle at the end of systole. So a way to think about that is after the ventricles squeeze and eject their blood, the volume of blood that is left, because the heart does not eject all of the blood from the ventricles. There is some blood left in the ventricles when they contract. The volume of blood that is left in the ventricles at the end of their contractile period is the end systolic volume. So using all three of those, we can come up with the equation stroke volume is equal to EDV minus ESV. So let's think of why that is. EDV, the heart is relaxed, the ventricles are at their fullest point, so there's a lot of blood in the ventricles. Then the heart squeezes and there is some blood left in the ventricles at the end of that squeeze. That volume is the ESV. So EDV, the ventricles are full. ESV, the ventricles have some blood left. Well, where did the blood go? There was a lot of blood in the ventricle. Now there's a little bit of blood in the ventricle. Where did that blood go? Well, that's the stroke volume. That was ejected from the ventricle. So there we have two different equations with stroke volume included. A couple of other factors: preload, contractility, and afterload. So let's see what those are. Preload is the degree of stretch on a ventricle. This is when the ventricle is relaxed. So during the period of diastole, remember, it is filled with blood. That volume of blood is the end diastolic volume. That blood is stretching the walls of the ventricles, and that degree of stretch is preload. Why do we care how much stretch is applied on the walls of the ventricles? Well, remember, muscle, skeletal muscle, and now cardiac muscle, when muscle is slightly stretched, that increases the number of cross-bridge interactions, and the result is we can get a stronger contraction. So preload and EDV are directly related to each other. As EDV goes up, there's more blood in the ventricle. If there's more blood in the ventricle, preload goes up. And if preload goes up, what happens? Now we can contract the ventricle harder. Next, contractility. Contractility is the strength of a contraction at a single given length or degree of stretch. So if we have two cardiac muscle cells and they have the same degree of stretch, maybe they will contract with the same strength, or maybe one of them will contract a little bit harder. Why would one contract harder if they have the same degree of stretch? Well, things like calcium levels, things like sympathetic nervous system stimulation. Those kind of things can increase how hard a cardiac muscle cell contracts. If I have two cardiac muscle cells with the same degree of stretch, but I give one of them more calcium and one of them less calcium, the one with more calcium is going to contract with more force. That's contractility. It has greater contractility, it contracts with more force. Third, afterload. Afterload is the pressure in the aorta just prior to ejection of blood from the left ventricle. Let's think about that. When the left ventricle starts to contract, blood is ejected from the left ventricle into the aorta. But what does it have to pass through? It has to pass through the aortic semilunar valve. Well, when does that aortic semilunar valve open? When pressure in the left ventricle is greater than pressure in the aorta. So as the ventricle starts to contract, let's think about it in slow motion. As the left ventricle starts to contract, pressure continues to build inside the left ventricle. At some point, the pressure in the left ventricle is going to be higher than the pressure in the aorta. The moment that happens, then the aortic semilunar valve will open and blood will be ejected from the left ventricle. Now, if the pressure in the aorta is elevated, say because someone has something like bad cholesterol levels, well, now the pressure in the aorta is up, so the left ventricle has to squeeze harder because now the pressure has to rise even higher before that valve will open for ejection. So afterload is another way to think about it, the pressure that must be first overcome by the left ventricle before blood can be ejected. Okay, Bainbridge reflex. The Bainbridge reflex is one of two factors that are reflexes built into the heart, well, the heart and some of the vessels around the heart, that can directly increase heart rate. So one of them we will talk about next week. One of them, the Bainbridge reflex, we'll talk about here. The Bainbridge reflex is sometimes called the atrial reflex or the atrial stretch reflex. This happens when there is a sudden increase in venous return, the amount of blood coming back to the heart. When more blood is coming back to the heart from the body, then there's going to be more blood going into the right atrium. When that happens, the right atrial walls are going to get stretched a little bit. And this activates your sympathetic nervous system. When the right atrium stretches a little bit, it activates your sympathetic nervous system. And that, in turn, increases your heart rate. So if more blood's coming back to your heart starts to beat faster. And the reason is so that we can push that blood returning to the heart away from the heart faster. We do not want blood coming back to the heart very quickly and getting pushed away very slowly. That would create a pooling situation. The blood would sit at the heart a little bit too long. That could potentially run the risk of something like a blood clot. Now, factors affecting heart rate, some other things, well, there are things called chronotropic agents. Chronotropic agents are any factor that either increases or decreases heart rate. Chronotropic agents. A positive chronotropic agent causes the heart to beat faster. A negative chronotropic agent causes the heart to beat slower. So let's talk about calcium again. Calcium increases heart rate. So calcium is a positive chronotropic agent. Now, I don't see anything on here about it, but I want to go back up to contractility just to talk about something that you might hear called inotropic agents. Inotropic agents. Anything that affects contractility is an inotropic agent. A positive inotropic agent makes the heart beat harder. It increases contractility. A negative chronotropic agent makes the heart not beat quite so hard. It decreases contractility. So chronotropic agents affect heart rate. Inotropic agents affect contractility. So now we get down to your virtual lab activities. Make sure that you complete both of these this week and your case study. I'm not going to give the answer to this, but if you want to talk it through and get some feedback, I'm happy to help you with it. But otherwise, that's all we have this week for lab, and I will talk to you next time.